Hello, welcome back in the new year to our masterclass series on the challenges of IHC staining. I'm Bettina Winkler from Visiopharm, and today Colin Tristram will talk about the advantages of using cell lines as control tissue. Colin has spent the last 20 years developing, marketing, and commercializing a range of products for the IVD market, specifically tissue diagnostics. Colin is a founder and current CEO of Histocyte Laboratories. He studied medical microbiology at Newcastle University, specializing in immunology. Handing over to Colin to start the webinar.
So I'd like to start by thanking Visiopharm for inviting me to talk in this webinar. I've been asked to talk about the cell lines. So Histocyte is a business built around quality control. When we employ the use of cell lines as a means of creating standardized material for use in immunohistochemistry and indeed in situ hybridization in laboratories around the world. The question of how this all came to be is really having an understanding of where variation occurs in laboratories and how it affects not only the quality of the tissue, but the output of these assays that are employed in the laboratories. So to really understand this, one has to look at what happens to samples in the lab and where variation occurs. And arguably the two biggest critical areas are around the sample collection and tissue processing. And sample collection is affected by a number of factors. The fixatives, certainly the fixatives can vary around the world, and the quality of the fixatives and the timed fixation as well. But probably more critical to that is the cold ischemic time, so the time the sample takes to be fixed. One has to understand or appreciate at least that once a sample is taken from a body, a whole series of cascade of events occur that begin the degradation of that sample. So protein starts to denature. That's the whole point of fixatives. We prevent that, and we try and preserve the tissue in as close a state as possible to when it was in the body in order to make the diagnosis. The second critical area is around tissue processing. So it's true that laboratories try and standardize these processes, and they have protocols that are validated, and these protocols that are kind of a one size fits all. So you will have a whole number of samples put in at the same time to be processed. And those samples can vary significantly in terms of content. Breast samples, some of them can be very fatty, for example. All those components are innate variation, and as a consequence, they can all have subtle differences between them. But nevertheless, this is the best practice. We use protocols that are kind of applied to everything. We also have to understand that these instruments use reagents, various alcohols, xylenes, and they get diluted over time, they get contaminated. And of course, depending on when those reagents have been changed, they, of course, can have an effect. So, samples processed with fresh reagents can sometimes show differences to those processed with old reagents. When you look at the other areas, embedding, so stuff can be, material can be wrongly embedded, and they just melt out and re-embed it. The other areas around sectioning, so sometimes sections thickness can have quite an effect on the immuno just by virtue of there being more protein there. So you will get stronger results with thicker sections, for example. But these tend to be standardized and validated in the laboratory around whether they use routinely 3, 4, or 5 microns. Step 5 of the assay is conducted is really the only point you can use controls to establish that the assay has been run effectively. So you want to demonstrate that the assay has worked the right way, the same way as it worked the last time you used it, be that yesterday, the week before, or a month before. This is the importance of controls. It's very difficult to control for those pre-analytical variations, but if you can demonstrate that your assay has been effectively run properly, it gives you a greater degree of diagnostic confidence. That's not to say one shouldn't look at internal controls in the tissue. That's vital that that analysis is done as well. Lastly, with interpretation, having the confidence to know that the assay is run properly, one can assess it more comfortably. But the cell lines are lending themselves to not only that, but the analysis is performed via image analysis. So these cell lines are addressing some of the challenges that affect the laboratories. And there are three big drivers really around the use of cell lines. One is, as I mentioned before, all those variations create an issue with tissue. The second big driver is the laboratories struggle for much of this material, particularly for some of the rare mutations. And the last part that isn't always appreciated is the cost to laboratories to actually manage their control materials, particularly for some of these high volume assays. So we're going to look at those in a bit more detail. The variation that you can see in the laboratories and in the samples, heterogeneity is probably the greatest with a lot of the tumor markers. Now, a lot of controls, they will suggest you use normal tissue because the expression tends to be more stable. But the problem with normal tissue is these are cancer diagnostic labs and they tend to be diagnosing cancer. So you don't necessarily always have an abundance of normal tissue. And certainly even when you have kind of samples, resections that have normal elements in, they are often in close proximity to the cancer and as a consequence can have some localized change. But nevertheless, those samples are not necessarily in abundance. And if they are, they're used for a wide variety of different markers. But the heterogeneity you see in cancer can be quite stark. So, for example, a composite block that has, HER2 samples in a 3, 2, 1 plus, they can start off that. That's how they've been selected. But, within microns, your samples can change considerably. And it raises the question for the operator of, has my assay varied or are all my tissues just heterogeneous? And more often than not, it will be heterogeneity and they need to discard it and find more control material. The image there from a publication by Nita et al. Shows you in very close proximity, a 3-2-1 expression for HER2. You also get other things in materials like retraction artifacts and crush artifact, which can give you false staining. And then, of course, there are issues affecting sometimes larger samples around fixation gradient. But as I mentioned in the beginning, the critical element is getting them fixed. And underfixation is probably to the greatest detriment of the sample rather than overfixation. Our cells are fixed and processed in a standard method that's equivalent to tissue, and thus we aren't affected by these same problems that affect tissue. The other driver is the struggle for samples in the laboratories, particularly those low or mid expressing samples, particularly things like HER2, ER, PR. But as I mentioned before, a lot of labs struggle, certainly the smaller labs struggle for some of the rarer biomarkers such as ALK or ROS1 in lung. Sometimes labs will have a large resection and they'll have plenty of control material, but for most small to medium-sized laboratories, they really struggle to find these. And it's not surprising. I mean, these mutations occur in maybe less than 3 or 2% of non-small cell lung cancers. Whilst the assays often recommend the use of things like appendix, looking for wild-type staining in ganglia, the appendix is already kind of ubiquitously used for controls for many other assays. So again, to my point before about those normal tissues that are used, the demand on them is so great that they run out very quickly. The other thing we see in labs is, and there's a hang-up from back in the day when we used to use things like pressure cookers or microwaves for epitope retrieval, batch controls were used, and they were appropriate at the time because all the slides were generally treated together in a batch. But now slides are independently treated on these machines. All of them are kind of separate from one another. So you can't really use a batch control in the sense that all these slides will be treated the same way. They're just not on the machine anymore. So the last thing I think that affects them is the greater volume that comes from this. So having to use same slide controls means that the amount of material they need is really great, and it's a great demand on these laboratories. So they tend to run out quickly. So for the large hospitals, even though they might get these resections and they might have a greater abundance of material in their archive, they just simply run out due to their volume. And as mentioned already, the small hospitals tend to struggle just because they don't have such a depth of samples in their own collections. The last factor that is becoming a greater driver as hospitals or laboratories are becoming more aware of the real cost to them in managing their controls. So often when asked how much their controls cost, the immediate answer is, well, it doesn't cost us anything because it comes from our archive. But when laboratories start looking at just how many scientists are involved in going through the database, identifying potential samples, potentially retesting them, there's a cost to retest them. There's a cost to get the pathologist involved, their time taken away from actually doing the diagnosis and looking at to archived samples. So that all of this is a drain in time, resource, and cost. Some laboratories make their own TMAs, and it's not uncommon for cores to fall out, making the block redundant. As I mentioned before, variation that can occur through heterogeneity, just the heterogeneity of these proteins in the samples, means that in some cases within a few microns a block becomes useless, and in some cases they just don't have as much sample in that block as they first thought, so they're cut through very quickly. When laboratories take into consideration all these costs, they frequently outweigh the cost of buying controls. And what a lot of laboratories are starting to do now is they will buy 4 to 6 blocks. When they get in up to 300 tests from a block, they will buy what they need for the year, and they will validate in the first block. And unless all those blocks are from the same batch, they don't need to do any more validation for the year, and they can not have to worry about the sourcing controls for be it HER2 or ER or PR as an example. They're good for the following 12 months. We are often asked about how the cells are fixed and processed, because laboratories want to use controls that are fixed and processed. It's the same as their own material, the material that they're testing in the laboratories. But they can't really quality control for that. I mean, we know how they're fixed and processed, we know how they work, and we know from the QC that they work in an appropriate manner with the standardized assays that laboratories use around the world. And probably the biggest consideration for them is, whilst it's nice to have samples that are fixed and processed the same, a lot of them are testing samples from other hospitals. So, most of the time, the samples they're testing aren't necessarily fixed and processed exactly the same as the tissue controls they might wish to employ. And each tissue is different. As I mentioned at the very beginning, it's very hard to control just by the very nature of tissue and how it's made up. I think this is very well illustrated when labs can demonstrate good EQA results on their tissue. It's not surprising. It's what they use day in, day out, and their assays are generally kind of adapted for the material that they see in their laboratory. What they often complain about is the referred samples from the EQA bodies. So this is centrally sourced tissue disseminated to these laboratories, and they test it. And most of the time they'll complain that the material from the EQA isn't that good. We can't get it to work as well as ours. And that just shows you that there is variation from laboratory to laboratory, just based on how they're fixing and processing their samples. It's not what they do is wrong. What they do is fit for the purpose in their laboratory. They get appropriate results. But to think that everybody is working in a perfect manner is perhaps not so true. So with our cells, what we look to do is answer a couple of issues, which were that cells typically don't look like tissue. So they're quite abstract. So we wanted something that would be more familiar. After all, immunistic chemistry is very aesthetic. We feel comfortable looking at things that are familiar with us. So that was the first part of this for histocyte, was creating a solution that looked more like tissue. And in doing so, we wanted to retain the morphology, better morphology. So we fix or harvest the cells in a proprietary manner. That means we retain some of that original morphology. And that's critical, we think, because it's not just about the amount of brown that you get. The localization is obviously very critical. You want to see membrane markers localized in the membrane, and nuclear markers in the nuclei, and so on. The morphology can tell you how the slide's been treated generally. So those images in the bottom there are showing you image 1 is a gold standard for in situ hybridization, looking at HPV. 2 and 3, clearly the sample's been over-digested. So that morphology is really important in situations like that. It will show you when samples are over-retrieved, for example. So because we QC with these standardized diagnostics from the main vendors, we're able to show that they work in an appropriate manner. And therefore, when the laboratory use our samples, they're not having to use tissue in their lab that can vary and can sometimes mean that assays need to be adapted in order to cope with the variation that they see in the samples. It's not uncommon. The problem with that is that you start getting drift in quality of tissue, drift in the assays. So our controls will prevent that. And this is where it's important that laboratories are always looking at the quality of tissue in their laboratory and looking at internal controls. So the controls are one thing, but looking at internal controls in the patient sample are critical. Like with ER, for example, looking at normal ducts if they're there to see that they stain appropriately. If they don't, then there is potentially issues at a pre-analytical level. However, our controls are making sure that the standard and quality of the assays are maintained and they don't drift. For QC only, I think it's really important to stress the importance of tissue. Really what we're doing by providing these cell lines is reducing the drain on resource in the laboratory, reducing the need to be creating countless tissue blocks. The QC will simply say the assay has worked, and if you're using the semi-quantitative controls, that you've got an assay working at the right sensitivity. And it's important that the laboratories validate what's normal in their lab. So they develop a baseline of performance in their lab with these controls, because each lab has its own subtle variations, mainly through the protocols they employ and some of the local issues that will affect them. It does not aid diagnosis. It can't be used as an equivalence. So a level of staining in a core is equivalent to the level of staining in the tissue. That's not what they're there for. They're there to show you that the assay has worked the same as it did yesterday and the day before. So with regards to tissue, they complemented by cells, but you still need tissue for validating assays. I have had customers want to use their cell lines to validate assays. You can use it as a control in the validation of an assay, but you can't use it to validate the assay. Tissue is vital. These are clinical assays that they need to be validated on clinical samples. You can use the tissue for troubleshooting through your internal quality assurance. I think most EQA groups that review samples want to see tissue, or tissue as well as cells if you use those routinely. But also it's part of the incoming QC. Not all laboratories necessarily do it in a specific manner, but you should be looking at receipt of new reagents and how they perform. And of course the cell lines can be used, but you want to see it on your own tissue. So I think it's important to stress that you still need tissue. What we're doing is relieving the burden on the laboratory for the volume that they require. As I said before, each of these assays work appropriately with our controls, but they have their own subtle differences, be it created locally or the fact that they're different chemistries. So they have different aesthetics, but they should produce the same result in terms of you have a negative, low, mid, high sample. They should look appropriately negative, low, mid, high on each of the platforms and the chemistries that they employ. They just might have different shades of brown, for example. But even with the LDTs that some of the laboratories have, they still need to create what's normal for their laboratory. We call it this baseline. Laboratories need to determine what that looks like across the platforms they employ. So if they use one for the breast work, for example, or 2 or 3, they need to show that they work consistently across those. And through the week, the working week varies, the operators vary, and with the samples they may cut and store them for when they need them. They need to determine that they are stable in that period. If they keep them on the bench, they keep them in the fridge, that needs to be validated in their laboratory. Without that, it's hard to see how you confer, greater confidence in your results. You need to essentially validate them for use in your lab. And with the advent of Qualitopix, we are seeing with our QC a means of being able to create a greater metric around measuring our QC. So we're able to determine how the assays work, because immunohistochemistry is not kind of a linear reaction. It doesn't work in a consistency. There is a tolerance, and when it falls out of that, that's where we want to capture it. It's not an exact science by virtue of the multiple steps involved, the chemistry and the samples that we use. So we rely on our eyeballs to measure that, but with the advance in image analysis and the technologies that are available, we're able to get a better handle on those. And with time, I would like to think that in combination with enough data, with the technology available, we're not just going to be able to determine whether the assay's worked and how well it's worked, but if it's not worked, what's gone wrong and what was the cause of that error, so that we can fix these things in a better real-time fashion. At the minute, we often find that the problems disappear as soon as they come, and none the wiser as to why they've happened. And I think in future, creating a greater degree of robustness around that element of immunohistochemistry will only be a good thing for both the industry and for the laboratories. And thank you for your time.